Just take a moment. Yeah. So good evening, everybody. I take this opportunity with the permission of. Can you hear me?
Yes, sir.
Yeah.
Yes, sir.
Yeah. With the permission of our beloved president and chairman of the Women's Wing, and all of you who are present here today, it's an honor to really start the meeting today as a secretary of IMA State Branch. So now we know that the academic activities have been well started across various committees in the IMA KSP, and one of the very active committee of IMA KSP is Women's Doctors Wing actually. And we must appreciate the chairman and members of the committee to take so many initiatives to bring in a lot of activities. It's going to be one of the outstanding year for the Women's Doctor Wing in 2023. So with this, I'd like to start with IMA prayer. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಿ. ಜೈ ಹಿಂದ್, IMA ಚಿರಾಯುವಾಗಿರಿ. Thank you so much. It's over to you, Chairman sir. Thank you.
Thank you so much.
Thank you. Yeah.
Request Dr. Shiv Kumar Lokal sir to say a few words of encouragement for our first PG.
Yeah. Really, it is very nice to see you all. Good evening to all. IMA KSB in association with Women Doctors Wing. We are having something different name nomenclature like webinar series PG Patashala. Really, it is a very nice to hear this voice. We are going back to the olden days, but still it is a very good concept from the side of the Women Doctors Wing chairman and all the members. Dr. Karnakar, our KSB secretary, and Dr. Vijay Sharathi, the treasurer of our KSB, and chairman of the Women Doctors Wing, Manpreet Kaur Madam, and all the esteemed members of Women Doctors Wing. Today we are having this webinar series, the very good topic, cancer prevention, role of LBC, that is liquid-based cytology. This is in connection with the cervical lesion. This is a very important, useful topic. Daily we can have a practice all over the state and also in the country to detect early detection of the cancer of the cervix, and so that we can treat 100%, and also we can very well give a fruitful life to patients. In connection with this, I welcome our President-elect Srinivas sir, also joined now. So welcome sir. So today we have got two speakers, very eminent speakers from STM Harvard, and Dr. Pavitra SS and Dr. Anita PG. They are the professors in STM Harvard. They will speak on this, and we can very well take up the message that they will give, and we can adapt in daily practice so that we can do good thing for the society. So with this few words, I wish you all the best, and I hand over the mic to chairman of this Women Doctors Wing. Thank you.
Thank you so much for your encouraging words, sir. Thank you so much. Dr. Srinivas sir, President-elect for the next year. He's with us, sir, now. He's joined us. I request him to say a few words. Dr. Srinivas sir.
Dr. Srinivas.
Srinivas sir. Srinivas sir.
He's joined us, sir. He's
Yes,
here.
yeah, ma'am. He's here. I can see. Srinivas sir, can you hear us?
John, is he got the connection?
He's
joined,
sir.
no?
Yeah. His audio and video both are available. I'll just call him, sir, once.
Please.
Okay.
This is to the PG students. In another 2 minutes, we will be starting with the academic session. And we will be finishing on time, so please don't worry. But just bear with us. Just another 2 minutes and we will be starting the session.
Hello. Hello. ಜಾಯಿನ್ ಸಿಕ್ಕಿದ್ರ ಕನೆಕ್ಷನ್ ಆತಾ?
ಇಲ್ಲ ಸರ್, ಫೋನ್ ಕನೆಕ್ಟ್ ಆಗ್ತಾ ಇಲ್ಲ ಸರ್.
ನಮ್ದು ಫೋನ್ ನಾನು ಹಚ್ಚಿದ್ದೆ, ಕನೆಕ್ಟ್ ಆಗ್ತಿಲ್ಲ. ಯಾಕೆ?
ಗೊತ್ತಿಲ್ಲ, ಕನೆಕ್ಟ್ ಆಗ್ತಾ ಇಲ್ಲ.
ಅವ್ರು ಈಗ ಜಸ್ಟ್ ಜಾಯಿನ್ ಆದ್ರ ಮೊದ್ಲಾಗಿದ್ರು?
ಇಲ್ಲ ಸರ್, ಒಂದು 5 minutes ಆಯ್ತು ಸರ್ ಜಾಯಿನ್. ಈಗ ರಿಂಗ್ ಆಗ್ತಾ ಇದೆ ಸರ್ ಕಾಲ್.
ಸರ್ ಬಿಸಿ ಇದೆ ಅಂದ್ರೆ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಬಿಡಿ. That's much better. ಈಗೆಲ್ಲ ಆಡಿಯನ್ಸ್ ವೇಟ್ ಮಾಡ್ತಿರ್ತಾರೆ. ಜಸ್ಟ್ ಸ್ಟಾರ್ಟ್ ಅಪ್ ಸರ್, ಮೇ ಜಾಯಿನ್ ಲೇಟರ್. ಮೇ ಬಿ ಬಿಸಿ ವಿತ್ ಪೇಷಂಟ್ ಅನ್ಸುತ್ತೆ ಮೋಸ್ಟ್ಲಿ.
ಸರ್ ಮಾತಾಡಿನ್ ಸರ್, he is trying to connect again.
Sir, should we wait?
Hello.
Hello. Sir
Yes,
is here now.
Sir is here. Srinivas sir?
Yes, sir.
Yes.
Can you? Yes, sir. Go ahead, sir. Everybody is waiting for your address to
Sir, we request you
women
to.
doctors.
Yes, sir. We request you to say a few words for this first PG webinar that we are going on behalf of Women Doctors Wing and IMA KSP, sir.
Good evening, Srinivas sir. Can you hear me? Stuck atala matta. Connection bala poor.
Howd sir, mat stuck ಆಯ್ತು.
ಅಲ್ವಾ?
Yes sir,
Okay.
yes sir.
Okay. ನೋಡಿ, go ahead, ಯಾಕಂದ್ರೆ everybody is waiting ಅಲ್ಲ.
Yes, so should I go ahead, sir?
Yeah.
Okay. John, can I have the first speakers?
Yes.
I'll be introducing the first speaker, Dr. Anita Javalgi. She is Dr. Anita will be the first speaker if I'm not mistaken. Yeah, okay. Dr. Anita Javalgi, who is trained in oncopathology at TMH Hospital, Mumbai. She is a professor in the Department of Pathology in STM Dharwad, as sir said, a very esteemed institution. Her areas of interest are GIT pathology, oncopathology, molecular and cytopathology. She has a lot of achievements, academic achievements to her credit. She won the first paper award in Cytocon annual conference in 2018, best poster award at KCAAPM in 2011, conducted the quiz for postgraduate students and consultants. John, I've lost the slide. Yeah. Conducted the quiz for PG students and consultants at Quizmasters at KCAAC 2019, IAPM 2020, APCON 222, and CAPCON in 2021. She has published 32 research papers in various national and international index journals. She's presented 19 presentations at state, national, and international conferences. Her research projects, and she is involved in 2 funded research projects which are ongoing. She was the honorary secretary of IAC Karnataka chapter since 2018. She is the executive member of KCI APM 2021-22, and she is a life member of various.
Connection ಆಗೋದು ಸರ್ ನಿಮ್ಗೆ? ಅಲ್ಲ, ಆಗ್ಲೇ 2-3 ಸಲ ಕರೆದಿ, ನೀವು ಸ್ಟಕ್ ಆಗ್ಬಿಡುತ್ತೆ. ನಾನು ಹೇಳ್ಬೇಕು. ಹೌದಾ?
Yes, ma'am, you can continue.
Okay. And she's a life member of various associations, IAPM, IAP, ID, IAC, MAPI, KCA, PM, KCIAC. She is a very sincere worker. I have worked with her when we were together in the same institution in Bijapur, and a very intellectual person. Dr. Anita, and I request you to start with the scientific activity of the day.
Thank you, ma'am, for the wonderful introduction.
Oh, just a minute, ma'am. Yeah. Srinivas sir, can you hear us now? Srinivas sir.
Srinivas sir?
Srinivas sir. I think he can't hear us, ma'am. It's okay, we'll start.
Okay, Anita ma'am, can you please start?
Yes, ma'am. Thank you for the wonderful introduction, ma'am. Can I share my slides?
Yes, ma'am, you can.
Can you see the slideshow?
Yeah, we can start.
Okay.
Yes, we can. Yeah.
Good evening, everyone. At the outset, I thank IMA and Women's Doctors Wing and Manpreet ma'am for this opportunity. Today's talk is on role of liquid-based cytology in cervical lesions. Before I start, I would like to dedicate my talk to Dr. Vijay Domble, who taught patients in pathology, Dr. Ravikala Rao, who showed what passion is all about in pathology, and of course, our patients who are the material providers in pathology. Disclaimer, this presentation is only for teaching purpose for today's session. The content is purely educational, and I declare there is no conflict of interest. My content of the presentation includes introduction to liquid-based cytology, Bethesda system of reporting, and non-neoplastic lesions of cervix. So liquid-based cytology is study of cells through a liquid medium. It is a technique introduced and tried long back, and it was FDA approved in 1996. And later on, this liquid-based cytology was used for various non-gynae samples as well. We all are aware of papillary, the pap smears in cervicovaginal lesions, which was very well introduced at the same time. This is the conventional pap smear and a liquid-based cytology preparation. I would just like to introduce how the slides are prepared, the procedure of LBC. For a comparison, I have here conventional pap smear, where the material is being taken from the cervicovaginal area in a brush, smeared on a slide, and the brush is discarded. So we can observe that not all the material is transferred on the slide. Part of the material which is there in the brush is discarded. Part of the slide material is taken on the slide and processed for papinicular stain. This is the conventional pap smear. It has its own advantage and disadvantage. Moving on to liquid-based cytology, the example I've taken is thin prep, where the same brush is been immersed in a solution which has been provided by the company, and the solution is further processed, sent to the lab and processed. It is centrifuged, the sediment is taken, and the slides are prepared. And this is how the slides look. So this is the liquid-based cytology procedure which is done in our institute, where we take the sample, which you can see number 1. Please follow my arrow. Number 1, which is processed, centrifuged under 1000 resolution per minute for 5 minutes. The supernatant is discarded. The blue color sediment is further processed. A solution is added, which is provided by the company. And then the sediment is processed and staining is done. And that is these two round structures are nothing but the material which has been prepared in a liquid-based cytology. To compare conventional pap smear and liquid-based cytology, we notice that conventional pap smear has majority of the cells are not captured, as we observed in the procedure itself. Part of the material has been discarded. So, and the remaining material, there is a lot of material which is obscuring the cellular morphology, and clumping and overlapping of cells are seen. Whereas in liquid-based cytology, virtually all cells of samples are collected and randomized representative transfer of cells are seen. Even distribution of cells is noted, and there is very minimal material, unwanted material, which will obscure the cell morphology. So the advantages of liquid-based cytology is like, it is a simplified procedure. Cell morphology and infectious organism morphology is better retained in liquid-based cytology. Background like necrotic material, hemorrhagic material, or sometimes excessive inflammatory material, which obscures the normal, the cellular morphology, is lost here. During the process, the background material is lost, which is helpful to understand the cell morphology. Turnaround time of reporting is very short because it is the material, as we observe here at the right hand side at the LBC and the conventional pap smear. I have put it here. The conventional smear is very widely spread on the slide, whereas here it is just the area to be screened is small, and hence we quickly see the slides to screen and report. Material remaining in the vial can be further used for ancillary tests, say that HPV. And this facilitates automated or digital cytology. These are the advantages of liquid-based cytology. Moving on to the disadvantages, which are very few. It is a costly procedure and laborious. Slight architecture and morphology alterations are seen, which down the experience, you pick up those morphological changes. And background material is lost, which is sometimes negative, because background material sometimes help us to diagnose certain cases, which gives us a clue to diagnose certain cases. Moving on to the second content of my talk, that is Bethesda reporting system. So it has the following headings, where we see specimen type, which is conventional pap smear, liquid-based preparation, or any other way of preparation. So that is the mentioning of specimen type. Then we look for the specimen adequacy. Irrespective of what smear we are seeing, we look for the adequacy. Then we general categorize, which is optional. The mandatory part is the one which has to be mentioned in Bethesda reporting. So specimen adequacy is mandatory to be reported, whether it is satisfactory, unsatisfactory, and quality indicators to be kept in mind. I will be discussing in detail these things. General categorization is optional, which includes negative for intraepithelial lesion or malignancy, epithelial cell abnormality, or other. You may mention, may not mention in your report. Interpretation or result is very much important to be mentioned in the report, which again includes NILM and epithelial cell abnormalities, which is squamous cell, glandular cell, or other malignant neoplasms. And any other additional points like any ancillary test done like HPV or P16 on immunocytochemistry, it can be mentioned. And computer-assisted interpretation of cervical cytology or any other educational notes or comments can be mentioned. So today I'll be covering up till the negative or intraepithelial lesion, and further the epithelial cell abnormalities will be taken in the second part by Dr. Parinita. So what is satisfactory? Satisfactory smear, whether it's conventional or liquid-based cytology, we have certain criteria to be defined. So adequate number of cells, well visualized or preserved squamous cells or squamous metaplastic cells. In a conventional smear, minimum of 8,000 to 12,000 cells have to be visible. Whereas in liquid-based cytology, as the area of screening itself is small, minimum of 5,000 cells is enough to call it as adequate. And women with post-chemotherapy, radiotherapy, or post-menopausal atrophic changes, even or post-hysterectomy where vulval lesion smear is being done, wall smear is taken, less than 5,000 cells is sufficient to, can be considered adequate, provided the cell count is more than 2,000 cells. Exceptions are in certain cases where we see abnormal cells, very minimal quantity of material is present, but we can make out the abnormality, then again we call it as adequate. Moving on to unsatisfactory, more than 75% of the cells obscured by inflammation or bacterial organisms or any other substances like lubricants or blood, then we call it as unsatisfactory to report. 50 to 75% of cells obscured include a disclaimer describing how and the percentages of the cells obscured. So whenever we define, if it is more than 75% cells obscuring, then we call it as unsatisfactory. But always we have to have an explanation why we are calling any slide as unsatisfactory. And report specific reason for unsatisfactory evaluation, whether the specimen is rejected or not processed or processed, but unsatisfactory for evaluation. So we should be very clear whether the specimen received was rejected because of some reasons like labeling or any pre-analytical mistakes, or it was processed, but after processing, the material was very less. And so we have called it as unsatisfactory. That has to be mentioned. Moving on to quality indicators. It's the presence or absence of endocervical transformation zone component. At least 10 well-preserved endocervical or metaplastic cells have to be seen. Absence of transformation zone does not necessitate repeat testing, provided if you have enough adequate material to comment on the lesion or the smear. So I'll continue with negative or intraepithelial lesion or malignancy, which includes squamous metaplasia, keratotic changes, tubal metaplasia, atrophy, pregnancy-associated changes. These are all cellular findings which are non-neoplastic. Then benign cellular changes. Then we have reactive cellular changes which are associated with specific conditions like inflammation, follicular cervicitis or lymphocytic cervicitis, radiation, intrauterine contraceptive device changes. And then we have glandular cells post-hysterectomy. Sometimes glandular cells are seen. Then infectious organisms like Trichomonas vaginalis, fungal organisms morphologically consistent with Candida, shift in flora, that is bacterial vaginosis, then bacteria which is consistent with actinomyces species, usually seen in IUD ladies, cellular changes with HSV infection or cytomegalovirus infection. And then we have others and endometrial cells. If we see endometrial cells, then it has to be correlated with the age group and the menstrual cycle. So these all are the subheadings under NILM. So moving on, before going to metaplastic changes, let us see what is normal LBC or a normal pap smear consists of. So it has a squamous cells, which are nothing but the cervix is a non-keratinized stratified squamous epithelium, which has a basal cell, parabasal cell, intermediate cell, and superficial cell. Then we have endocervical cells in the smear, which I'm showing in the figure, and this is the cytology which we see on the pap smear. The endometrial cells, which sometimes shed and come in the cervicovaginal smears. And the lower uterine segment cells, that is the cells from the lower uterine segment. So this is the squamous cells, which is basically, as I've told, the parabasal cells, intermediate cells, and superficial cells. The first left-hand side upper end shows a superficial cell, which is largest cell among the pap smear. This is large polygonal cell with 16 to 17 mm size, which has abundant eosinophilic cytoplasm, a very small pycnotic nucleus where the nuclear details are not visible or clear. And then we have certain keratohyalin granules in the cytoplasm. Usually the superficial squamous cells are predominant in pap smear or the LBC under the effect of estrogen, high levels of estrogen. Maybe it's late proliferative phase or ovulatory phase. Wherever the estrogen levels are high, we see in smears superficial squamous cells to be predominant. Moving on to the second type of cells which we see in pap smear is the intermediate cells, which are slightly smaller than the superficial cell. The size varies to 12 to 16 mm. It has a very classic thin transparent basophilic cytoplasm. And there is a nucleus which is slightly large, measuring 35 micron meter with clear nuclear features visible. It has a vesicular nucleus and very uniformly distributed granular chromatin. Third group of cell is parabasal cell, which is smaller in size. Before that, intermediate cells are usually predominantly seen on the pap smear where the progesterone effect is very high. So it is seen usually in early follicular phase of menstrual cycle, luteal phase, or second and third trimester of the pregnancy. So whenever there is progesterone effect is high, we see intermediate cells. Moving on to the third group of cells, that is parabasal cells, which are smaller in size, say 3 to 7 millimeter. It has a dense bluish homogeneous cytoplasm and a large nucleus with measuring around 50 micron and has a fine uniformly distributed granular chromatin. The parabasal cells are usually seen when there is lack of estrogen, say postpartum phase, postmenopausal, or premenstrual. So parabasal cells are predominant in premenstrual age group, postpartum lady, or postmenopausal. And sometimes we might get in pap smear the basal cells, which are very much few, and they are smaller than the parabasal cells with high NC ratio, but uniform nuclear membrane contours and chromatin distribution. Moving on to the second group of cells, that is endocervical cells. Endocervical cells are tall columnar cells which measure 16 to 18 millimeters. It has a distinct cell cytoplasmic borders. The nucleus is eccentrically placed oval and has a fine granular chromatin, and occasionally it might show prominent nucleoli. In pap smear, the arrangement of endocervical cells can be seen in a picket fence pattern, which is seen on the in the arrow showing, and the honeycomb pattern. Moving on to the second group of cells, the endocervical cell, endometrial cell. Sometimes in pap smear, we do get endometrial cells, and it is normally seen on the first 12 days of menstrual cycle. These endometrial cells are smaller in size, very smaller compared to endocervical and the squamous cells. They are 1 to 2 millimeter small, cuboidal in shape, have high NC ratio, and nuclei appear to be hyperchromatic, oval or bean shaped. They're normally seen with a scant cytoplasm, normally seen in the first 12 days of menstrual cycle. After 12th day of menstrual cycle or above 45 years, if endometrial cells are seen in pap smear, it says it's a significant finding and has to be further keenly observed for any pathology. They usually come under a 3D clusters. And the last group of cells, which sometimes we seen in the pap smear, is the lower uterine segment cells, which are nothing but again the endometrial cells, which are diffusely, discohesively spread out. So coming to the non-neoplastic findings, which includes squamous metaplasia, keratotic changes, tubal metaplasia, atrophy, and pregnancy-induced changes, we will look into one by one. Squamous metaplasia is further categorized as mature and immature. Mature squamous metaplasia represents change of columnar, that is endocervical cells, to squamous epithelium. So change of one epithelium to other epithelium is metaplasia, and here we see the columnar is changed to squamous. Tendency to form sheets of cells here. The cytoplasm shows various differentiation in maturity, the squamous metaplastic cells. They have multi-angulation, where as we are seeing in the picture here, and the nucleus is, the NC ratio is less than 50%, and the cell membrane is of the nuclear membrane is smooth and uniform and has evenly distributed chromatin. So these two pictures shows squamous metaplasia, where we see a mild high NC ratio and the endocervical cells have changed to squamous cells. This is mature squamous metaplasia, where the cytoplasm shows a certain differentiation of maturity. Moving on to immature squamous metaplasia, these are the sheet of cells which have narrow rim of immature cytoplasm. The cytoplasm is less and it has a large nucleus and prominent nucleoli, as we can see here. On the right side, the picture is very clear with few cells are showing multiple prominent nucleoli and many cells are showing single prominent nucleoli. The NC ratio comparatively is high, and the cytoplasm is immature. Usually they mimic a parabasal cell. So this is immature squamous metaplasia. One has to be very careful while checking, while looking into the slide for squamous metaplasia, because sometimes they mimic the squamous intraepithelial lesion. Moving on to keratotic changes. Keratotic changes are nothing but the hypermaturation of the native squamous epithelium, a protective reactive phenomena. This is, as we know, the cervix is stratified squamous epithelium, but as a protective reactive phenomena, the keratinization may be seen. And usually this is associated with human papilloma virus infection. So the keratotic changes are categorized as parakeratosis or hyperkeratosis. Parakeratosis is seen nothing but the proliferation of layer of small nucleated squamous cells with pycnotic nuclei, which they come in the sheets. The NC ratio is low. Cells have dense organophilic or eosinophilic cytoplasm, as we can see in this figure. Nuclei are small and pycnotic. In smears, miniature keratinized squamous cells are seen either singly or in sheets. So the most important finding of parakeratotic cells is organophilic or eosinophilic cytoplasm. Moving on to hyperkeratosis, these are enucleate cells, otherwise unremarkably mature polygonal squamous cells with ghost nuclei. So we just see a lot of keratin is seen here and the nucleus is lost. So there is hyperkeratosis here seen in this picture. Now parakeratosis sometimes may mimic there's something called dyskeratosis, which are commonly seen in squamous epithelial abnormality, and that one has to be clear about when to call dyskeratotic change, where we notice the nuclear atypia or nuclear abnormality, and in parakeratosis there is no such nuclear abnormality. Coming to the tubal metaplasia, which is seen here in the photograph, we can see the columnar endocervical cells in small group or pseudostratified crowded cells. These are nuclei round to oval, enlarged, mildly pleomorphic and hyperchromatic nucleus. There is overcrowding seen. Chromatin is evenly distributed and inconspicuous nucleoli. prominent terminal bars, the cilias are very clearly seen. So it's a tubal metaplasia seen in this photograph. Moving on to atrophy. Atrophy is nothing but a large number of parabasal and basal cells are seen. The parabasal cells are, because of the lack of estrogen, the maturation is affected, and hence parabasal cells have come under the smears. So these parabasal cells are seen diffusely, sometimes in the sheaths or syncytial cells, and they have preserved nuclear polarity and mild nuclear overlap is seen. Now again, atrophy, one has to be very careful when we look into the atrophy, because they mimic again squamous intraepithelial lesions at cell, which will be further discussed. Pregnancy-induced changes, most important pregnancy-induced changes are called navicular cells. It is nothing but the predominant cell, as we have already seen. Intermediate cells are seen in pap smear under the progesterone effect. These intermediate squamous cells show prominent glycogen, clear cytoplasm causing a flattened boat-like appearance, referred to as navicular cells. Nuclear vesicular with delicate chromatin structure. Moving on to reactive cellular changes, which includes inflammation, lymphocytic cervicitis, radiation, and IUD changes. So this is inflammatory induced changes where we notice typical repair may involve mature squamous cell, mature metaplastic cell, or endocervical cell. There is a wide variation in nuclear size ranging from normal to markedly enlarged, but with a round nuclear counters, even chromatin distribution and a prominent nucleoli. The important point to be noticed in reparative changes, the nuclear features, which should have a round, smooth nuclear membrane, and chromatin distribution. The size of the nucleus should be uniformly oval or round, and chromatin should be uniformly distributed. Then small perinuclear halo and intracytoplasmic polymorphonuclear leukocytes may be seen. So here the cell shows, as my arrow is showing, a perinuclear halo is seen in few squamous cells. And streaming nuclear polarity and interdigitating of cells may be likened as a school of fish appearance. So there is streaming of the cells. This is the follicular cervicitis, where we see formation of mature lymphoid follicles is seen in subepithelium, and when the smear has been done, we see a lot of polymorphs population intermixed with the lymphocytes with or without tingible body macrophages. This photograph shows a lot of lymphocytes and few scattered superficial squamous cells. So that is follicular cervicitis. Moving on to radiation-induced changes, these are the large cells with abundant vacuolated cytoplasm and bizarre shell shapes. Now, and the nucleus are variable in size with mild hyperchromasia, prominent nucleoli, bi or multinucleation is common. Nuclear degeneration with wrinkling or vacuolization may be seen. Now, radiation-induced changes has to be kept in the mind because they also mimic certain epithelial abnormality. And this is the last, that is the endocervical changes, that is the glandular cells or endocervical endometrial present in the clusters, where we see a large cytoplasmic vacuole, sometimes giving a signet ring appearance. Now, this morphology is important to be kept in mind because they mimic HSIL, that is squamous intraepithelial lesion high grade. And the glandular cells post hysterectomy status, here the glandular cells are benign, and these cells have mild enlargement of the nucleus and basophilic cytoplasm. And whenever we find more nuclear abnormality, the suspect of one has to rule out adenocarcinoma. So last part, moving on to the organisms. Till now we covered the squamous cellular changes of squamous metaplasia, parakeratosis, then the inflammatory changes, and moving on to the organisms. The most common infection of the cervicovaginal areas are the viral infection, HPV, HSV, CMV. That is herpes simplex virus and the cytomegalovirus. Bacteria most common are G. vaginalis, actinomyces, strep, staph, Neisseria gonorrhea, and E. coli. Fungi most commonly day in and out we encounter candidiasis infection, occasionally sometimes aspergillosis. In parasites, most common is Trichomonas vaginalis. Again, we come across this day in and out. Then we have occasionally we might come across S. hematobomium, that is Schistosoma hematobomium, Mansoni, or Rituria bancrofti. And sometimes amoebiasis also. Chlamydia is another. So while reporting, one has to, this is optional to report, but one, if you find, it is better to mention in your report if there is an organism infection. So we'll discuss the cases in the form of cases, how we'll end up this talk I'll discuss the cases with these taking common infections. Moving on to the case 1. 35-year-old female complains of white discharge, sometimes foul smelling since 2 months. And on systemic examination, nothing abnormal was noted. So on per speculum upper examination, there was a discharge seen. So this was the LBC picture where we could see a lot of inflammatory cells and few structures here. And hyper, I'll show you. These are the few pear-shaped structures with a pycnotic-like eccentrically placed nucleus under hyper view. This is another view where we can see kindly follow the arrow here, where we can see the organisms or the structures which have a bluish pear-shaped shape, which has bluish cytoplasm and small dotted like pycnotic nucleus. These are nothing but the pear-shaped organism, that is the Trichomonas vaginalis. So what are the microscopic findings or the hint when we look into the pap smear? Mainly there are a lot of inflammatory cells. The superficial cells show perinuclear halo. Once you see perinuclear halo, do search the Trichomonas vaginalis infection around the cells. And the organisms are classically pear-shaped, have eccentrically vesicular nucleus, and sometimes the nucleoli is also visible, and it has granules and flagella. Sometimes they are associated with leptothrix. That can also be seen. So these are the microscopic findings or the clues when we look into the slide. And how do we report this case under Bethesda reporting system? So the specimen type we saw was liquid-based cytology. The specimen adequacy, yes, it was adequate. That was satisfactory for evaluation. General categorization was NILM because there was no squamous abnormality or any epithelial abnormality seen. Hence, we called it as NILM, that is negative for intraepithelial lesion or malignancy. But what was our result or interpretation? There was benign cellular changes consistent with Trichomonas vaginalis infection. Moving on to case 2. This is 26-year-old female who complains of white discharge and itching since 2 months. Again, there was no systemic examination. There was no abnormality detected. Per speculum, there was a discharge seen. There was no erosion or any other abnormality. So let us go what LBC shows here now, pap smear. So this is under the low par where we see a clustering of cells and this classical appearance of the Rowley formation of the squamous cells here. Please do follow my arrow. The image shows squamous cells which have been arranged in a Rowley formation or in a line pattern. Let's go to hyper view because we can see some linear structures here. Hyper view, we can see pseudohyphae, the lot of linear tubular structures, and even hidden, there are certain spores. So this case is, by now you might have guessed what this case is. This is a case of candidiasis. So what are the microscopic clues here? It's a budding yeast or pseudohyphae or elongated budding show constriction along the length. So there is a tubular long structures which we see, and they're pseudohyphae and they're eosinophilic to gray brown on pap stain. And along with the fungal organism, we also see fragmented leukocyte nuclei and Rowley formation of squamous epithelial cells speared by hyphae. On LBC, we call it a shish kebab appearance. So this was a shish kebab appearance on LBC. So how do we report this case? Specimen type LBC, specimen adequacy satisfactory for evaluation. Yes, it was satisfactory. General categorization, again, it is negative for intraepithelial lesion. So there was no epithelial abnormality. And interpretation, cellular changes consistent with candidiasis infection. By mentioning the organisms, it is always convenient for the obstetrician or gynecologist to start with the respective treatment for that infection. Let us move to case 3. 36-year-old female on routine checkup. There was no other thing. She had come for hospital for routine checkup and a pap smear was done as a part of a health checkup. And here are the slide pap LBC where we can see a very clean background, superficially spread superficial squamous cells and intermediate cells. Predominantly is the superficial cells, and few cells are being covered with certain small bacilli and where the cell membrane is not even clear. So the complete organism or the small bacilli-like organism is covering the superficial squamous cell. And these cells are called clue cell. By now you might have guessed what this case is. Yes, it is a case of bacterial vaginosis or shift of flora. So what are the microscopic clue here or the microscopic findings in LBC? Small cocobacilli is seen in the background, which is absent in LBC. In LBC, the clue cells are very obvious. Squamous cells are covered with bacteria obscuring the entire cell and cell membrane called as clue cells. There is conspicuous absence of lactobacilli here. So how do we report this now? This is a LBC case now. Specimen type is liquid-based cytology. Specimen adequacy is satisfactory for evaluation. General categorization is NILM, and interpretation is shift of flora or bacterial vaginosis. Moving to the last case of our presentation, case 4, 35 years female, complains of dysuria and itching since 1 week. Again, systemic examination, no abnormality was noted, but per speculum, redness was noted and vulva showed red, tiny, irregular rashes. Let us see what we have here. Now here, for a change, I have kept a conventional smear to compare as well as to know what is the difference here and how to report. See, conventional smear, we can see the lot of cellularity is there, lot of background material is also visible. Under high power, we can see certain multinucleated giant cells and few nuclear molding. Let us go to high power and see what is that. See, here we can see a multinucleated giant cells. There is nuclear molding at certain cells. So by now you might have guessed what this case could be. Yes, this is a case. Let us see what are the microscopic findings and then we'll see what the case is. So we appreciated multinucleated giant cells, ground glass appearance of nucleus, yes, which I forgot to mention earlier. There is a ground glass appearance here. Then prominent nuclear molding, and 3M are very eminent here: multinucleation, margination, and molding. And inflammatory cells are seen in the background. So this is a case of herpes simplex virus infection. So how do we report this? Now here the specimen type we saw was conventional pap smear. And of course it was adequate to report. General categorization was NILM and interpretation is cellular changes consistent with herpes simplex virus. So this completes our 4 cases where I have discussed the organisms. So that completes my talk where I have covered NILM lesions, that is benign cellular changes, and what all we have to look into benign cellular changes and what are the mimickers which we have to keep in the mind to differentiate it from the squamous epithelial lesions or glandular epithelial lesions. I would like to acknowledge, and my references for certain photographs are Bethesda system for reporting cervical cytology by Ritunaya ma'am, and I had undergone the online certificate course where the material was very well provided, which I have used in my presentation, and of course my cases were from my department. Thank you. This is my institute. I thank you, Dr. Manpreet Kaur ma'am, again for giving me this opportunity, and I hand over the second half will be taken by Dr. Parinita SS, who will be covering on the epithelial abnormalities. Thank you.
Madam, you are muted.
Am I audible? I'm not muted.
Yes, ma'am.
Am I audible?
Yes,
Yes.
ma'am, you're audible.
Okay. I request the PGs, if whatever questions they have, they can put it in the chat box and we can take them all together at the end of the session.
Yes, ma'am. Yes, ma'am.
Yeah, I'd like to introduce the next speaker, Dr. Parinita. Again, a dedicated teacher and an intellectual in her own right. Can I please have a slide, please, John?
Yes, ma'am.
Okay, Dr. Parinita again is a professor in the Department of Pathology, STM CMSH, STM University, Dharwad. Her areas of interest are urogynec pathology, nephropathology, oncomolecular and cytopathology. She has published various research papers in various national and international index journals, secured the second rank to RGUHS University in MD pathology, has been a speaker in various CMEs, scientific committee member for Karnataka chapter of Indian Association of Pathologists and Microbiologists. She's an ex-EC member of KCI APM. She's involved in various research projects for the institution, has completed clinical and nephropathology in basic and advanced certificate course from International Society for Nephrology, and she is a life member of various associations, IAPM, IAC, KCI APM, KCIAC. I welcome you, ma'am, and I request you to start with your scientific session. Thank you.
Thank you, ma'am, for the wonderful introduction. without much delay, I'll just share my screen. Ma'am, is it visible? Is it visible?
No,
No, ma'am. No, you
Yeah.
have to start from
Yeah,
screen
I'll
share.
just, yes. Visible?
Yeah, it is visible. You can full screen and start.
Okay. I thank the organizers for this opportunity. Today, basically, I'll be dealing with the epithelial cell abnormalities in the cervical lesions. So as per 2014 Bethesda system, epithelial cell abnormalities broadly, they are categorized as squamous cell abnormalities and glandular cell abnormalities. In squamous cells, as you know, in the reporting pattern, what we give is it can be atypical squamous cells where they are of undetermined significance or where we cannot exclude HSIL. Then we report it as either LSIL, low-grade squamous intraepithelial lesion, or high-grade squamous intraepithelial lesion, or squamous cell carcinoma. These are the various entities what we report under squamous cells. So similarly, in glandular cells, we have atypical glandular cells, we call not otherwise specified. They can be endocervical, they can be endometrial, or when we are unable to differentiate sometimes whether they are endocervical or endometrial, then we give it as glandular cells. Okay, then they can be atypical endocervical or glandular cells which favor neoplasia, or it can be a in situ adenocarcinoma, or it can be adenocarcinoma. Again, in adenocarcinoma, it can be endocervical type, endometrial, or it can be extrauterine type. Okay, and then other malignant neoplasms can be seen. So what are the commonly encountered problems by the pathologists? As you can see, there are a lot of reactive changes which mimic malignancy and which mimic in situ lesions. Okay, and some of them what I have listed are atrophy. Especially this atrophy gives a lot of problem to pathologists because they show a lot of high NC ratio. That nuclear to cytoplasmic ratio will be very high in atrophy. So this always gives us problem. And reactive changes in smears can vary from mild reactive change to a severe reactive change. So most of the times we are in a state where whether to call it a ascus or whether to call it a reactive change. Next is the metaplasia. Okay, when the metaplasia is mature and mature, it's very easy to comment on metaplasia. But especially when the metaplasia is immature and if the metaplasia is showing atypia, then again it's a problem to the pathologist. Then coilocytes. Coilocytic atypia, whenever we see coilocytes, then we have to categorize it under low-grade squamous intraepithelial lesion. But sometimes there are a lot of mimickers which look like coilocytes. So we have to categorize whether it's a true coilocyte or whether it's a pseudocoilocyte. Next, the intrauterine device will have certain effects on the cells where the cells can show a lot of atypia. Then radiation effect. That also gives a problem where the nuclear atypia can be seen. And the glandular cells atypia, whether they are glandular cells or sometimes a high-grade HSIL lesions can look like glandular cells, or they are endometrial or endocervical, whether they are due to reactive change or due to neoplastic process. It's a challenge for us. You can see this is an atrophic smear where lot of these cells in singles, they are showing high NC ratio. Basically, they are atrophy smear will show a lot of parabasal like cells, and these cluster of atypical cells can also be seen in atrophy. So these cells, there is a lot of cardiomegaly. So anybody will think of calling it as a low-grade squamous intraepithelial lesion, but this is actually a reparative atypia, what we are seeing in an intermediate cell. So similarly, these are clusters of endocervical cells which are showing reparative atypia. So these give lot of challenges to the pathologist to categorize them as to what they are. So now moving on to the cells proper, how a atypical cell, when you should call what. Okay, regarding that, atypical squamous cells, we have two main categories: atypical squamous cells of undetermined significance and that of HSIL, where we cannot exclude HSIL. Okay, to call atypical squamous cells, the cells should show increased nuclear to cytoplasmic ratio when we compare with the normal one. As Dr. Anita has already discussed the normal things, you might be already knowing the normal squamous cells, they have particular ratio, okay, of nuclear to cytoplasmic ratio that will be increased and should show some nuclear changes. Just increase in the NC ratio, we cannot categorize all of them into atypical squamous cells. You should see some nuclear changes to call or categorize a case under atypical squamous cells. So what are the nuclear changes? A hyperchromasia, mild hyperchromasia can be there. Chromatin clumping can be there. Irregularity. These all changes will be subtle, but you will definitely notice some nuclear changes. In that scenario, you call it as atypical squamous cells. Then based on the amount of nuclear changes, you categorize whether it is of undetermined significance or whether cannot exclude HSIL. When we give ascus, that is of undetermined significance, usually cells mimic that of LSIL nature. Okay, whether means you cannot categorize whether it is due to LSIL or due to a reactive change. Okay, that is the gray zone where we call it as atypical squamous cells of undetermined significance. And most of the times you have to call when there is subtle nuclear changes. Okay, and atypical squamous cells cannot exclude HSIL. We call when the cells mimic more of HSIL, but all the features of HSIL are not there. So then you categorize it as atypical squamous cell cannot exclude HSIL. So when we call of undetermined significance atypical squamous cells, the nuclei will be 2.5 to 3 times that of an intermediate cell. Here you can see there is a normal intermediate cell. Here there is a cardiomegaly and there is mild hyperchromasia. Okay. So these are categorized under atypical squamous cells of undetermined significance. So what all patterns fit under ascus are? There is coilocytosis, but it is incomplete coilocytosis. Means all the features of coilocytosis are not there. So what is coilocytosis? Coilocytosis is HPV-induced change where we see perinuclear clearing in the cytoplasm. Along with that, there will be nuclear changes like irregularity in the nuclear membrane and hyperchromasia. All those things we see in coilocytosis. But all these features, when they are lacking, okay, and there is only focal perinuclear clearing and mild increase in the nuclear size, then it is incomplete coilocytosis. That time you categorize it under ascus. Okay, and atypical parakeratosis means that there are parakeratotic cells which are showing atypia. Okay, those cases also should be categorized as ascus. And there is a repair cells. Okay, reparative atypia cells are there, but they are showing definite atypia. Such cases you put under atypical squamous cells of undetermined significance. So like this, this is a case where you can see there is a increase in the nuclear size and there is some amount of chromatin clumping. Okay, this was categorized as ascus, but the biopsy showed it to be low-grade squamous intraepithelial lesion. So when do we call atypical squamous cell cannot exclude HSIL? Basically here the cells are smaller cells, those of parabasal type. Okay, the smaller cells, and they have very high NC ratio where they mimic high-grade squamous intraepithelial lesion. Okay, so the patterns which come under atypical squamous cells cannot exclude HSIL are basically they are smaller cells. Okay, when the cells are of intermediate cell type, you categorize them under ascus because they are mimickers of LSIL. Okay, when they are of parabasal type with high NC ratio, you categorize them as ASC-H because they mimic HSIL. Okay, so especially immature metaplastic squamous cells are there. If they are showing atypia, then you categorize them under ASC-H. Then there are crowded sheets of cells with markedly atypical repair. Okay, their mild atypical repair you consider under ascus. Marked atypical repair you consider under ASC-H. Severe atrophy, okay, with atypia you can consider under ASC-H. Then post-radiation changes that are very much concerning type of atypia is there, where you cannot tell whether it is a residual carcinoma or a radiation change. That time the category of ASC-H is reported. Like this case, the same picture what I showed before. This is a case where you can see these cells. Okay,
These are parabasal size cells, where you can see there is a high NC ratio, the nuclear to cytoplasmic ratio, and there is hypochromasia in these cells. And pap smear, and cells are not many, very few cells are there. So this pap smear report was ASK-H, and the biopsy turned out to be immature squamous metaplasia. This immature squamous metaplasia mimic HSIL-like cells. So when the cells are not very sufficient, not many cells, and all the features of HSIL are not there, you put it under a category of ASK-H, so that biopsy can be done. So another case where these similar cells with high NC ratio, then there are focal nuclear irregularities are there, and this was categorized as ASK-H, and the biopsy turned out to be high-grade squamous intraepithelial lesion. So here you can make out that the cells are smaller, the cytoplasm is less mature compared to intermediate and squamous cells. So these are basically parabasal type of cells and categorized as ASK-H. So there are mimics which mimic the cells of ASK-H. Like sometimes isolated endocervical cells, normally we see in honeycomb groups. Okay. Sometimes these isolated endocervical cells, they look like these parabasal cells with high NC ratio and all. So they may mimic ASK-H cells. So you should be able to look, you have to look at the cytoplasm. They will have a fine vacuolated cytoplasm. So based on the cytoplasm, you can rule out that these are endocervical cells. Then degenerated endometrial cells sometimes can mimic ASK-H-like cells. Macrophages, okay, they also mimic. Then intrauterine device patients, okay, they shed some cells which are of extremely high NC ratio. So that resembles HSIL. And some pregnant and postpartum patients, they will have atypical appearing industrialized stromal cells. So in these patients, we may wrongly report it as ASK-H. Okay. Rather, I would not call wrongly report. Rather, that is how because it is subjective, and when in so many scenarios it is so difficult to categorize them as to what. So this category of ASK-S and ASK-H help the pathologist and also help the patient for a better treatment. So based on the guidelines, whenever we give ASK-S, HPV testing has to be done. Though in India, not much of HPV testing is not done. Okay, but the regular guideline is whenever ASK-S is given, then test for HPV. HPV is negative, then follow up with 3 years is fine. If HPV comes positive, then refer for colposcopy and look for the lesion. On colposcopy, if there is no lesion, again, after 12 months, the testing can be done. Then ASK-S cytology with no HPV result, then just repeat cytology after 1 year. If it is ASK-H, then colposcopy is recommended because the cells are mimicking HSIL and the progression of HSIL to malignancy is faster. So go for colposcopy, look for the lesion, and then accordingly management is suggested. Okay. So now, till now, we just learned about atypical squamous cells, when to call of undetermined significance or cannot exclude HSL. So we learned about ASK-S and ASK-H. Okay, when do a pathologist report? Okay, next is about intraepithelial lesions. These are very important lesions because the main purpose of pap smear is for early detection. Right, so the early detection is the reason for pap smear, and identifying squamous intraepithelial lesions is very important to a pathologist, and that is the sole reason of the pap smear. Okay, so in malignancy, you will see the growth. Most of the times the gynecologist knows that it is malignancy, there is a growth, there is induration, but it is in the intraepithelial lesions, the role of pap smear is more. Okay, so in squamous intraepithelial lesions, it can be a low-grade squamous intraepithelial lesion, it can be a high-grade. Okay, and in high-grade squamous intraepithelial lesion, if there is a suspicion for invasion, then we put those cases under HSIL. Okay, with features which are suspicious, not definite. If invasion features and tumor diathesis are definite, then you put it under squamous cell carcinoma. So what are the features in a LSIL? What are the features in a HSIL? We'll just see. LSIL is basically a same like ASK cell. What I told you, they are basically intermediate and superficial squamous cells which are showing the nuclear changes. So the size is large with abundant cytoplasm. Okay, the nucleus is enlarged compared to the normal counterpart of an intermediate and superficial cell. But overall NC ratio compared to normal, it is more, but the cells have lot of cytoplasm. and it should show nuclear changes. That's very important. So the nuclear changes, what we commonly encounter in LSIL is a hyperchromasia, but chromatin will be distributed regularly, means a uniform distribution we see. And nuclear membrane, sometimes they can be smooth, sometimes it can be irregular. We see multinucleation, binucleation and multinucleation. And whenever we see coilocytosis, the coilocytic atypia is categorized under LSIL. Okay. And in liquid, there is difference between the cell morphology in a liquid-based cytology and a conventional smear. There is slight difference. So we need to have the we need to be more familiar with the changes in the LBC. Whenever we shift from a conventional smear to a LBC, a pathologist may encounter certain problems. Okay, so there are certain changes, but basically the cells are less. Overall, what are the features in a LBC? The cells appear less. Tumor diathesis we don't see. So, and the cells appear smaller compared to the conventional. So these are certain problems, but as you get used to it, then it is easy, and rather your sensitivity is very good. Okay, so in LBC, the cells of LSIL, there is no much problem because they show similar features as that in the conventional smears. It is in HSIL we have a problem because the cells appear smaller in LBC. So you can see this is a smear showing there is a cardiomegaly here. There's a cardiomegaly here. This is 2.5 to 3 times. Such cells we categorize under ascus. When the cardiomegaly is definitely more than 3 times that of a this is a normal intermediate cell. When it is definitely more than 3 times, then you have to think of LSIL. So this is the coilocytic atypia, which is categorized as LSIL. You have to report this coilocytic atypia as low-grade squamous intraepithelial lesion. It is a HPV-induced change where typically we see perinuclear halo and there is binucleation. Certain amount of nuclear irregularity is there, and then there is a dense cytoplasm around the perinuclear halo. So what we should know as a pathologist, there is something called a pseudocoilocytic change. It can occur in Trichomonas vaginalis infection. It can occur in high glycogen content in the cells. Okay, so we have to categorize. This is easy, but in Trichomonas, this case is easy. Easily we can tell it is not a proper coilocyte, but especially in Trichomonas vaginalis patients, we see a lot of pseudocoilocytic change where it mimics very much like a coilocytic atypia. So these are the typical low-grade squamous intraepithelial lesions where you can see that they are basically intermediate size cells, okay? And there is hypochromasia. This is called smudging of the nucleus, where chromatin you are unable to appreciate properly. There is multinucleation and abundant cytoplasm we appreciate in low-grade squamous intraepithelial lesions. Okay, so what are the problematic patterns, especially borderline changes? When it's difficult sometimes whether to call it as a ascus or LSIL. Then herpes cytopathic changes, even they can mimic LSIL, radiation changes, then pseudocoilocytosis. These are the problems which we encounter routinely. So how the recommendations for LSIL is less than 25 years. If there's LSIL, you follow up with cytology at 12 months because the progression of LSIL to malignancy is slow. Then 25 years and older, HPV negative, then go for a retesting after every 3 years. HPV positive, then go for a colposcopy examination and then biopsy if the lesion is appreciated. Okay, then coming to HSIL, that's high-grade squamous intraepithelial lesion. In high grade, here the cells are of parabasal type. As I told you, the ASC-H is the HSIL cells, they look like ASC-H. Okay. So the HSIL cells, they are smaller cells and they show less cytoplasm maturity. And NC ratio is higher, nucleus is hyperchromatic, the membrane can be irregular, whereas in LSIL, not much of irregularity. Here the membrane irregularity is conspicuous. Nucleoli generally absent but can be seen. Okay, and here the cytoplasm, it can be two ways. It can be an immature cytoplasm or it can be a mature. Mature we usually say when there is a keratinization. So if it's a keratinizing HSIL, then you can see keratin in the cytoplasm. If it's non-keratinizing type, then you need not see keratin. Okay, it can be a lacy delicate. Basically the cells are smaller compared to the LSIL cells. So you can see, as you have seen the previous pictures of LSIL, you can see that the cells are smaller but high NC ratio. The cytoplasm has reduced and here the nuclear size is much higher. Okay. So these are the cells of a high-grade squamous intraepithelial lesion. So these are the cells of a high-grade squamous intraepithelial lesion, but you don't see any tumor diathesis. So they are categorized under HSIL. So in LBC preparations, in liquid-based preparations, basically you see a lot of dispersed cells, and the cells may appear smaller compared to the conventional type. The high NC ratio and nuclear membrane you will appreciate. The main thing is the cells appear a little bit smaller, and sometimes flattening at the edges of the cell cluster can be seen. Okay. The problems in HSIL when there is immature squamous metaplasia, it's really sometimes difficult when the metaplasia is immature and it is showing atypia, whether to call atypia in a immature squamous metaplasia or it is a HSIL. Similarly, atrophic smears, it's difficult. So this is a liquid preparation. Sometimes the cells will be so scant. It's a challenge for the pathologist. You can appreciate these cells. These are the HSIL cells. So this is a case where pap smear was reported as HSIL and cervix biopsy confirmed. Here you can appreciate that these are basically smaller size cells. Means smaller size means compared to the cytoplasm of these intermediate cells, the cells are high NC ratio is there. Cytoplasm is lesser compared to the intermediate cells. Okay, and this is a biopsy showing the HSIL. So there are certain mimics of HSIL. Sometimes these histiocytes, they can mimic HSIL cells. Then deserialized stromal cells can mimic HSIL cells. Then hyperchromatic crowded groups. Hyperchromatic crowded groups is a terminology used for cells of endocervical or endometrial type where they don't show cytoplasm, only the nuclear clustering is there. They look like a cluster of grapes, okay, without cytoplasm. So these cells, we categorize them as HCGs, that is hyperchromatic crowded groups. Okay, they are actually endocervical or endometrial cells, and these can mimic like HSIL cells. Okay, whenever there is a report is of HSIL, then we have to confirm with the cervix biopsy and go ahead with the management. Now we have learnt about LSIL, HSIL. Now coming to squamous cell carcinoma. See, now HSIL also includes in situ carcinomas where invasion is not seen, or you have a suspicious areas of invasion, you consider them under HSIL. Now, when to categorize a case as a squamous cell carcinoma for a pathologist, when you see tumor diathesis and lot of tumor cells, lot of atypia, very bizarre cells, then you categorize them as squamous cell carcinoma. Like again in squamous cell carcinoma, it can be keratinizing type, it can be non-keratinizing type. In keratinizing type, it's easy to identify, whereas in non-keratinizing type, they can mimic glandular cells. So non-keratinizing SCC becomes a challenge. So keratinizing squamous cell carcinoma will show a lot of variation. Here you are seeing, as we are moving from HSIL to SCC, the pleomorphism, nuclear changes are very significant. Okay, there's marked variation in the cellular size and shape, and you will see some of the spindle cells. And I'll tell you what are these spindle cells. They are nothing but keratinized cells. We call them as tadpole-like cells. Then nuclear membrane is irregular, then granular, irregularly distributed. Then you will see a lot of keratotic changes like hyperkeratosis, parakeratosis, and tumor diathesis. This is very important to categorize a case as squamous cell carcinoma. So what is this tumor diathesis in a smear? A necrotic debris and broken down blood elements together form a background in a smear. Okay, that is tumor diathesis. The problem with the LBC is the amount of tumor diathesis is less in liquid-based preparations, and tumor diathesis is more in conventional smear. But this is a double-edged sword. This tumor diathesis sometimes obscures the cell morphology so much that it is difficult to diagnose in a conventional smear because it's all filled with the necrotic material and blood elements. Okay, whereas in LBC, tumor diathesis is less. You are appreciating cell morphology better, but the thing is tumor diathesis is very minimal. So there are high chances that you call it as a high-grade squamous cell intraepithelial lesion rather than a malignancy, squamous cell carcinoma. So you can see this is a keratinizing squamous cell carcinoma. These are all keratinized dysplastic cells, and this is a spindle cells like cell. Okay, these are all atypical squamous cells, and there is some amount of tumor diathesis here, background necrosis you can see. And in LBCs especially, tumor diathesis is reduced, and whatever tumor diathesis we see is adherent to the atypical cell clusters. So we call this as clinging diathesis. Okay, you can see that around the tumor cells, the diathesis is more. So non-keratinizing squamous cell carcinoma, same as squamous cell carcinoma, in that keratinization is there. In the keratinizing type, here the keratinization is not there. So the challenge becomes sometimes they mimic adenocarcinoma cells. Okay, they are comparatively smaller. The marked irregular distribution of coarse chromatin. Here the nuclear changes are very significant. Nucleoli may be prominent, and tumor diathesis is more in non-keratinizing squamous cell carcinoma. So what about SCC in a liquid-based preparation? Compared to conventional, the low tumor cellularity and tumor diathesis is less. Okay, here diathesis is subtle in LBC preparations compared to but as we get used to, as we get experienced with the LBC, then it's easy to identify. Okay, the thing is cleansing diathesis common in the LBCs. Okay, and sometimes these rounding of individual cells occurs in liquid-based preparations, and because of this rounding of the cells, this imparts glandular appearance, and management is cervix biopsy for the SCC. A sample report, epithelial cell abnormality, squamous, means under general category, epithelial cell abnormality, you give squamous. Then satisfactory evaluation, you have to analyze. Interpretation, if it's high-grade squamous intraepithelial lesion, you call it as high grade, or if it's a SCC, you call it as SCC. So basically they are put under general category of which abnormality it is. Then you tell about the adequacy, then you interpret the slide and any suggestions you want to recommend. So after we have finished squamous, we have glandular cells. Okay, so the epithelial abnormality cells in the glandular cells, again it is categorized into atypical glandular cells, NOS. Okay, then atypical glandular cells which favor neoplasia, then adenocarcinoma in situ, then frank adenocarcinoma. Okay, so here basically in a pap smear, what glandular cells we see is endocervical cells, endometrial cells. Okay, sometimes difficult to differentiate whether it's an endocervical or endometrial, then we just call it as glandular cells. Okay, so similarly in adenocarcinoma, it can be endocervical, endometrial, or it can be rarely extrauterine. Okay, so when do we call atypical endocervical cells? So first you have to identify endocervical cells, and if you are seeing atypia in endocervical cells,
Dr.
then
Parita,
yes, ma'am.
I'm really sorry, but they have another Zoom at 8. So
Yeah.
we
How much time is there, ma'am?
Ma'am, it's 7:46 already, and they need the platform at 8 sharp.
Yeah,
So,
ma'am. Yes, I'll go ahead with I'll complete. Okay, ma'am.
thank you.
Another 5 minutes.
Yes. Atypical endocervical cells, when do we call? When you see atypia in the endocervical cells. Okay. So atypical endocervical cells favor neoplastic. Here, the nuclear changes are higher compared to the endocervical cells of NOS. Okay. So you see lot of overcrowding, you see pseudostratification, and in the endocervical cells, there is some elongation of the nuclei, and at the periphery of the cluster, you see feathering. Okay, this feathering, overcrowding, and elongation of the nuclei, they all favor neoplastic change in a endocervical cell. So atypical endometrial cells is, as Dr. Anita has already discussed about normal endometrial cells, you identify them as endometrial cells, and there is atypia in the endometrial cells, that is mainly the nuclear changes, then you categorize it under atypical endometrial cells. Sometimes it's difficult to call whether they are endocervical or endometrial cells, like especially these tubal metaplastic cells. If you're seeing atypia in tubercle metaplastic cells, or where you are unable to categorize, you call them as atypical glandular cells. So what's the management for an atypical glandular cell? So colposcopy with endocervical sampling, and if the patient is also at risk of endometrial neoplasia based on the age and other features, then go for endometrial sampling also. So next, when do we call adenocarcinoma in situ? Adenocarcinoma in situ features are vague glandular appearance you can appreciate, elongation of the nuclei you can appreciate, and the chromatin clumping is seen. Okay, and nuclear irregularities can be seen. And at the periphery of the cluster, there is more elongation and there is feathering at the cluster. Whereas a normal endocervical cells, as you have seen in the previous lecture, the endocervical cells will show honeycomb appearance. Okay, whereas in situ, you see this feathering at the edge of the cluster. So in liquid-based preparations, in situ, you also see this short bird tail-like appearance, and feathering also are seen. So what do we do when there is an adenocarcinoma in situ? Go for colposcopy and endocervical sampling. You can appreciate these are normal endocervical cells, and these are the vague acinar pattern and some amount of feathering, elongation of the nuclei you can appreciate. So next is about adenocarcinoma, whether it's an endocervical or endometrial adenocarcinoma based on the cell morphology you call. Though here the nuclear changes are very prominent, a lot of ATPI is there and a lot of tumor cells are there. So you can see there is a macronucleoli in these cells. You categorize this under endocervical adenocarcinoma. So this is another case of endocervical adenocarcinoma, willow glandular type. Lot of these tumor cells, and you know these are glandular cells. Okay. And tumor diathesis in endocervical adenocarcinoma is typically wispy. Okay, wispy, we call this as a cotton candy tumor diathesis. So endometrial adenocarcinoma, same. You are seeing atypical endometrial cells, and the nuclear ATPI is so distinct that you call it as a adenocarcinoma. The nucleoli can be variable, and here tumor diathesis, what we see is a watery or a finely granular tumor diathesis we see. So just to end the lecture, I have two cases. One is a 68-year female with a postmenopausal bleeding of 2 episodes. She's a para 4 living 4 with full-term vaginal delivery. This is a liquid-based preparation. So here you can see that there are a lot of cells which are showing high NC ratio. You can see these cells with high NC ratio, and there is nuclear irregularity. Big mitotic figure here. Lot of nuclear irregularities are there. Anyone who can give the answer from the audience? Okay, some more clusters of cells you can see. So this was reported as epithelial cell abnormalities squamous, and lot of tumor diathesis here you can appreciate. So this was called as squamous cell carcinoma, and biopsy confirmed as squamous cell carcinoma. So the next case is of a 49-year female who presented with a postmenopausal bleeding, and in this case the LBC showed very few atypical cells. We also had prepared a conventional smear for the case. So in the conventional smear we could see certain cluster of cells. However, the background was not very clear. So here I have just focused tumor cells. Actually the number of tumor cells were less. Here you can see they are vague glandular type cells. Okay, and there is high NC ratio and some amount of feathering at the edge. Okay, we called it as atypical glandular cells favor neoplasia. And subsequent biopsy was done, which showed willow glandular type adenocarcinoma in the endocervical region, later followed by radical specimen we received, and then the tumor was confirmed. So again, ending the session with a disclaimer that this is for education purpose. And the acknowledgement and references are Bethesda System for Reporting by Diane Solomon and Ritu Nair, and ICMR online certificate course, and Mind Institute cases. I thank my guru, Dr. Ravikala Rao Madam, for being the constant source of inspiration. I thank my institute for giving us the excellent infrastructure and the opportunity. This is the bird's eye view of our institute, and myself and Dr. Anita, we have just given you the bird's eye view of cervical cytopathology. There's a lot more, and you have to dive into the sea to know more. Thank you.
Thank you so much. Wonderful speakers. I'm sure the students have benefited. Now, before I say, I think the questions, we are really running short of time. So the questions, what I'll do is I request the students, whoever have any questions, they can DM me and I can pass on the questions to you and pass on the answers to them. Now we are honored to have Dr. Srinivas sir, President-elect IMA. Sir, would you like to say a few words for the students and for us? Dr. Srinivas sir?
Unmute, sir. Srinivas sir, unmute.
No, sir, it is unmuted, but we can't hear sir's audio. Sir,
That is the problem.
can you hear us? Srinivas sir. But we can't hear you, sir. Your audio. Your video is fine. No, sir. We still can't hear you.
Ma'am, in the meantime, can I say something?
Yeah, please, ma'am.
Yeah, ma'am. Myself and Dr. Anita, we like to thank Dr. Manpreet ma'am for giving us this opportunity. Thanks a lot, ma'am. It was wonderful being associated with you. At the same time, we would like to thank Dr. Shivkumar, sir, President of IMA, Dr. Karunakar, sir, Honorable Secretary of IMA, Dr. Vijay Sarthi, sir, Treasurer, and the esteemed IMA members who are part of this organization.
Manpreet ma'am, I think sir is still not connected. You can please close. By
Madam,
water.
we are also very much thankful for you on behalf of KSB. Really, the very well enlightened the topic. We are really overwhelmed with your all topic. We welcome you in future also. All the best.
Thank you.
Okay. Thank you so much. Sir.
Okay.
Thank you for your words, Dr. Srinivas, sir. We hope to connect with you next time. Thank you, John. Thank you, all the participants.
Manpreet, Dr. Manpreet, there's